afternoon, everybody, and welcome you all to the instruction course number 516. The topic here is actually pathophysiology of abnormality in the depth of anterior chamber in relation to phacosurgery. Now, why the topic is, actually, like when we start doing a surgery in the early days, we all remember that we come back and talk, man, every surgery feels different. But over a period of time, we see that we forget that and we start doing all the different grades of cataract nucleus extraction by phaco with the same setting. That means the level of comfort increases, but that's where, like it can put the surgeon in a difficult surgical situation if not prepared, leading to some complications. We all know about all these causes of deep anterior chamber and shallow anterior chamber, especially in reference to the perioperative shallowing of the anterior chamber is another important factor. Now, operative abnormal depth of the anterior chamber, we should be conscious about the causes like mechanical pressure by the speculum or the drape, leakage from the paracentesis or the main tunnel. There may be low inflow due to compression of the slip of the phaco-tip by a tight entry wound, and there may be fluid misdirection syndrome and suprachoroidal effusion or hemorrhage. Fluid misdirection syndrome is another very important point because at any level of the phacosurgery, even through the healthy zonules, the fluid may be directed to the vitreous, and there is a forward displacement of the lens iris diaphragm leading to a shallow intraoperative chamber. So just to remind that we can be conscious for the variation of the anterior chamber depth from the very beginning in the OPD, like from the history of VR surgery, trauma, connective tissue disorders, then refractive error status of the patient before surgery will give us idea about myopia, hypermetropia. A very small white to white diameter will give you indication about the nanophthalmic eye. Then anterior chamber depth idea can be have from before the optical biometers, anterior segment OCTs. And then the most important that we should not forget that even in an eye of normal or longer axial length with a shallow anterior chamber should give you an impression of possibility of pseudo-exfoliation syndrome because of weak zonules, the lens iris diaphragm comes forward. Now, how should we be prepared to handle it? So I picked a few points like use of special OVDs during the surgery. Like whenever we handle a shallow anterior chamber, it's very difficult, like because of the convexity of the anterior lens capsule, there's running out of the rhexis. So there's a need for, like cohesive viscoelastic. And to protect the endothelium, we should be ready with dispersive or whatever you call a soft cell technique or something like that. The question of using a cystitome or a rhexis forceps. Whoever is used to whatever it is doesn't matter much. But it's seen sometimes in a shallow anterior chamber. While using a rhexis forceps, there is a tendency of iris root prolapse. So sometimes you may have to shift from a rhexis forceps to a cystitome also. And then we'll be talking on the tunnel size and the location. The phaco-tip, basically, this is the vector force or the direction. When we work on a deep anterior chamber, it will be better to use a band Kelman phaco-tip, and always a bimanual irrigation aspiration is a better option. So the vector force inside the eye, like how the capsule is torn and how the phaco-tip reaches the lens as the surgeon is working at different AC depths, simply changing the band of the cystitome, we can make it useful for a shallow chamber or a deep chamber. Now related to the tunnel size and location. We all know a square tunnel is the strongest tunnel. So for example, if we use a 2.8 phaco-tip and use a square tunnel in the limbus, we are reaching almost half of the radius of the cornea. So when we go such a forward position and tilt the phaco-tip for a deep anterior chamber, say in high myope, you can see the red line depression of the cornea, which will distort your field of vision because of the corneal fold. So it's better in case of a high myopic to go little posterior, which maybe we call it a posterior limbal incision, or maybe a little scleral with little bleed, doesn't matter much. But you go less farther into the cornea. Reverse is the situation for hyperopic eyes. In hyperopic eyes, we should do the incision location a little anterior limbic, because the posterior lip of the tunnel will protect the prolapse of the root of the iris in this situation. So we should also keep in mind about the reverse pupillary block. We all know while doing a phacosurgery in a high myope where the iris is compressed backward, the pressure rises, chamber deepens, and the pupil dilates. Simply manipulating the iris or the capsular bag with the second instrument can be handled. And I think it's very important to observe this situation at the end of the surgery, even after putting the IOL. When you finish the surgery, if the chamber is left too deep and the pupil dilated, there may be subsequently postoperative pressure rise. To handle the intraoperative sallow-OSC, we should first look into loosening the speculum or the drape, or look for retrobulbar hemorrhage. If there is a leakage from the main port or the side port, we can hydrate the port, or even we can put a suture. And if there is insufficient flow, we should keep in mind that our entry of the phaco-tip into the main tunnel may be very tight. There may be compression of the sleeve, so little enlargement of the main tunnel will correct it. At the end of all these three small steps, even if there is a shallow chamber, I call it a finger test. You touch the globe a little bit and you feel it, that if it is hard, then you should not forget about fluid misdirection or choroidal effusion and hemorrhage. It's important to do an indirect ophthalmoscopy on the table to look into the retina. If the retina is normal periphery, then you should think about fluid misdirection. And if there is an elevated mass, of course, there is possibility of suprachoroidal hemorrhage and effusion. If there is fluid misdirection, that means the retina is normal, then we can do a vitreous tap with a 24 gauge needle, pass through the pars plana to the anteromid-vitreous and aspirate the fluid mixed vitreous a little bit, 0.1 to 0.3 ml around, so that the anterior chamber gets an adequate depth to work. But in case of suprachoroidal effusion and hemorrhage, we'll have to defer the surgery, maybe from a day 1 to day 7 until it improves. So to recognize a potential problem at the earliest is very important. Then making a sound diagnosis intraoperative and managing the situation at that particular moment scientifically is important to reduce the possibility of complications. So being alert and adhering to the general principles of surgery in abnormal AC depth conditions minimizes unfavorable outcome. So thank you very much. That's how I like to introduce the chapter, and subsequently the speakers will talk to you in details.